Ladies and gentlemen, some of the messages that I'm going to share with you in not more than the next 10 minutes are just common sense. For example, if I would ask into this room, who of you believes that a team approach is better than a standalone approach, almost everybody would agree. But I would like to go a little bit beyond that and also share with you the difficulties and the challenges that get along with everything in the field of hybrid and team that on first glance all of us love so much to really gain benefit and to improve quality of care. These are my disclosures. I have a couple of research grants via the University of Leipzig to disclose, but no personal relations, financial relations at all to disclose. What's the rationale for an AFNET team for rhythm control? It's management of complex cardiovascular disease, and I specifically did not put the word complex rhythm control in there, as I believe that this team approach goes beyond just restoring rhythm. And this is one of my key messages, as it means that we have to think cross-department, cross-sectional, cross-border structures when we really want to gain achievements with a true team approach. The goal is to optimize management and to fuse competences, to really fuse competences. Take what you don't have in your own brain, in your own experience from others to improve therapy. It's very important in an era which is clearly focusing on personal care and precision medicine. The more precise we want to approach the patient, the more fusion of the competences we need in order to gain benefit from that and to improve outcome. So the goal is to facilitate patient-centered, evidence-based, multidisciplinary care. Who should be part of the team? It's an important question, as the composition of the team is a marker for the effectivity and the livability and the success of the team approach. Of course, and I always say that this should be kind of the team captain. The electrophysiologist, as the electrophysiologist, is among the team setting the one who comes from the core of the business around rhythm control. A cardiac surgeon is one of the key persons that should be in the AFNET team. One prerequisite to have a cardiac surgeon there is that it should be somebody who cares about rhythm therapy, who has interest in atrial fibrillation surgical approaches. Only if you care for the idea to use a certain treatment strategy, you will care about the outcome of the patient. That's true for the electrophysiologist and for the cardiac surgeon as well. A cardiologist with particular experience in heart failure therapy significantly contributes, aside from what we as electrophysiologists with CRT could offer to this team approach. I was thinking about genetic competence. Do we need genetic competence at this point in time in a clinical-oriented heart team for rhythm control in AF patients? I do not think we need it right now, but it is something that we have to have in focus for the years to come. A neurologist to consult whenever specific questions around the field of optimal therapy to reduce the risk of stroke and keep the risk of bleeding as low as possible is definitely needed. And as I am a deep believer in imaging and delivery, visualization and delivery as one of the future main passes in cardiovascular medicine. A cardiovascular imaging specialist is a key person in such a team approach. It does not necessarily need to be a radiologist. I believe that all cardiologists, all big units in the future will focus on imaging with MRI technologies, advanced echo technologies, but I do not want to exclude our friends from radiology. Of course, they are very, very welcome if they gain and bring in the imaging experience. Imaging will play a key role to pave out optimized treatment pathways for individual patients. I am deeply convinced from that, and it goes beyond just the visualization of fibrosis and the DCAF2 trial. I believe it's of utmost importance in the field of atrial fibrillation and also in the field of sudden cardiac death. And last not least, we need an integrated care specialist. I'm always deeply impressed when I listen to Jerome Hendricks when he presents his data with such a huge benefit for the patient by providing an optimal infrastructure that connects inpatient with outpatient care, that implements and that includes treatment options that we do not have in our portfolio on a routine basis, with dietary care, with weight loss, with psychological support, with supporting the family. All these needs to be done by somebody who knows how this can be done. In theory, it's very convincing. Everybody would say, yes, we do it. But to bring it on the road and to successfully implement that is really a challenge. And somebody who knows how to do it as good as Jerome and colleagues is really needed. And last not least, part of the team is the patient family, and it's the engaged patient for shared decision-making. Only if we understand and implement the patient as competent in the decision-making team, we will gain most benefit out of engagement and shared decision-making processes. It's very difficult if you would like to bring such a team together with the goals that I've outlined to implement it into routine care. All our days in the hospitals are busy. We have discussion rounds, we have wards, we have scientific meetings, and now you have to add another meeting on a regular basis with the AF Heart team. This is the first challenge. Prioritize and give it time. It needs time, it needs infrastructure in order to gain benefit. I have summarized some of the steps that I consider particularly important as an infrastructural process to make it successfully happen. I think we need to do the following. We need to define subspecialties available and the team members, which can be a different setup in different institutions with different patients, different options, and different treatment tasks and treatment goals as well. We need to regularly schedule meetings to institutionalize that. If we do it only once per 3 months, it's something completely different as compared to once per week when we regularly discuss the patients and when we look for the patients that are problematic and that gain benefit from a multidisciplinary approach. Detailed definition of patient population and characteristics discussed by the AF team. There must be a general agreement what type of patients should be presented there as a role. Redesign, modification, optimization of treatment pathways. It is one of the tasks of such a heart team to look what we have and to understand what's currently going on in the medical structure that you are working in. You will be surprised if you do that, what you have and what you think you have, but at the end of the day you don't have, and what you miss and what you need to restore. The definition of available treatment options on-site and also referral options. There is nothing. It's a smart thing to do. It's a strong move if you cannot deliver a certain therapy which is optimal for the patient, to pave a treatment pathway as discussed by the AF Heart team to a colleague who can offer some type of therapy. Responsibility for patient guidance under the treatment process. Who's responsible for what? And most important, I'm deeply convinced of that, is the definition of outcome measures and quality control. Define quality indicators and define quality markers of what the AF Heart team recommends. Measure the outcome that you know what quality at the end of the day results from what you are doing. Are there data on team approaches? Yes, the EHRA did a survey on team approaches in electrophysiology just a couple months ago. And here are some results from that survey. When do people believe a team approach is needed? This is more or less common sense. When it gets complex, and as you see, refractory atrial fibrillation was quoted by 73% of the people that participated in this approach. How many of the hospitals that participated in the survey have AFHR teams? Only 50%. But those that have it, I would presume, with a different degree of strength of execution of what a team approach is, almost all of them are happy and see the benefits gained. Potential focus of the AFHR teams, what do I believe would gain most likely benefit for the patients? It's complex scenarios, particularly AF patients with heart failure, where I see a huge demand for a meaningful interaction between surgeons, heart failure specialists, and electrophysiologists. Redo cases, when you cannot succeed on your own, it makes particular sense to look to your neighbor or to your partner in order to improve. Indications for rhythm control: identify patients that qualify for and profit from surgical procedures is one of the key points for our heart team. Discuss indications for AV node with a team approach before you terminate AV conduction. Ultimately, it makes sense to rethink and to share that idea with others. The guidelines for atrial fibrillation management pave that out in the same way as they recommend for the first times what you should do if your initial rhythm control approach failed. And then it's the right time to call for the heart team. Recurrence is a very complex scenario where different mechanisms become operative. It is complex, and if we want to cope with that complexity, it makes sense to do that with a team approach. My last slide, I found this great article on the team approaches that has been written by Drs. Holmes and Michael Mack quite some years ago. As they said, evolving strategies of care under some cardiovascular conditions have identified the central role of the heart team in optimizing patient selection, procedural performance, and follow-up care in enhancing the process of patient education and informed consent. And the last sentence I would like to close with: the heart team concept forms the heart of modern cardiovascular care. Thank you very much for your attention.
Thank you, Gerd. Now we'll listen to the AF